Reproductive system, the pelvic floor. Introduction. A competent student at the end of this podcast should be able to describe the composition of the female pelvic floor and to describe the demarcation of the urogenital and the anal triangles of the perineum. The pelvic floor is the major supporting structure for all the pelvic viscera in both males and females. It is composed of two layers of diaphragmatic muscles. The pelvic diaphragm is the broad funnel-shaped sling of fascia and muscle that extends from the pubic symphysis to the coccyx and from one lateral side wall to the other. It forms the anterior-inferior border of the abdominal pelvic cavity. The urogenital diaphragm is inferior to the pelvic diaphragm. It contains muscle fibers that contribute to the constrictor functions of the urethra, vagina, and the anal canal. The pelvic floor muscles have two major functions. They provide support or act as a floor for the abdominal viscera, including the rectum. And they act as a continence mechanism to the urethral, anal, and the vaginal orifice. The internal genitalia for both males and females are supported inferiorly by the pelvic diaphragm. The external genitalia comprises the structures outside of the true pelvis and are suspended by the urogenital diaphragm. The perineal musculature have a different embryological origin than the musculature of the pelvic diaphragm. The pelvis is made up of two hip bones, the sacrum, and the coccyx of the lower spine. The area the pelvic brim surrounds is known as the pelvic inlet. The area surrounded by the ischial spines, the coccyx, and ischiopubic rami is known as the pelvic outlet. These bones are being held together in the shape of a basin by ligaments and muscles. The obturator foramen is the large, obliquely oriented aperture located at the inferior aspect of the lesser pelvis. It is bounded by the parts of ischium and pubis. The foramen is covered by thin fibrous membrane that serves as attachment sites for the internal and external obturator muscles. At its superior margin of the foramen, the membrane is devoid of forming the obturator canal, which allows the obturator nerve, artery, and vein to exit the pelvis and enter the medial compartment of the thigh. The obturator membrane is a strong fibrous membrane attaches to the margins of the obturator foramen. It almost completely closes the obturator foramen, except for the obturator canal. The obturator membrane provides attachment sites for the internal and external obturator muscles, which are critical for the attachment of the pelvic floor muscles. The sacrotuberous ligament is a stabilizer of the sacroiliac joint, and it connects the bony pelvis to the vertebral column. It has a broad fan-like origin from the sacrum, coccyx, ilium, and sacroiliac joint capsule. Its fibers converge to course caudally to insert into the medial ischiotuberosity and the ischioramus. Like the sacrotuberous ligament, the sacrospinous ligament is also a stabilizer of the sacroiliac joint, and it connects the bony pelvis to the vertebral column. This ligament is a triangular-shaped structure with its base attached to the anterior sacrum at about S2 to S4 level. The coccyx and its apex is attached to the ischial spine. Together with the sacrotuberous ligament, the sacrospinous ligaments forms the boundary of the greater and the lesser sciatic foramen, musculotendinous structures and neurovascular bundle to the perineum and the leg leave and enter the pelvis via these foramens. The perineum is the compartment of the trunk below the pelvic diaphragm. It consists of muscle fascicle formations arranged to close the pelvis inferiorly. The perineal region extends from the skin to the inferior fascicle surface of the pelvic diaphragm and occupies the area between the buttocks and the medial surface of the thigh. The perineum is bounded anteriorly by the pubic arch, laterally by the ischial tuberosities, and posteriorly by the apex of the coccyx. It has a rhomboid or diamond shape with its major axis directed anterior-posteriorly. A transverse line passed through the ischial tuberosities divides the rhomboid-shaped perineum into two triangular regions. The urogenital triangles anteriorly and the anal triangles posteriorly. The anal triangle contains external urogenital organs, perineal muscles, fascia, and sphincters. The anal triangle contains the terminal segment of the anal canal, the anal sphincters, and space filled with fat, which is known as the ischial-rectal fossa, or the ischial-anal fossa. The female external genitalia is made up of both urinary tract and reproductive structures. It serves the purpose of reproduction and urination. These structures collectively fall under the term vulva, which means covering. From the exterior observation, the female external genitalia appears to be covered or wrapped by skin folds. These skin folds are called labia majora and labia minora. The labia majora engorges with blood and appears edematous during sexual arousal. The labia minora are a pair of small cutaneous folds that begins at the clitoris and extends downward. Other major structures found in the vulva include the clitoris, external urethral orifice, the openings of the greater vestibular gland, and the vaginal orifice. Most anteriorly, the mons pubis, which is a fat pad located directly in front of the pubic bone. It is usually covered by pubic hair and is more prominent in females than is in males. To summarize, the female pelvic floor is composed of the pelvic and urogenital diaphragms. The perineum is the region bounded by the pubic symphysis anteriorly, coccyx posteriorly, and the two ischial tuberosities laterally. The female reproductive system. Internal genitalia. A competent student at the end of this podcast should be able to list the components of the female reproductive system and describe their main functions, to identify the major landmarks of the bony pelvis, to differentiate the greater and the lesser pelvis and identify the boundary that separates the two areas, to describe structures of the female internal genitalia and their relative position to other pelvic viscera, and to identify the anatomical spaces and pouches in the female pelvic cavity. Compared to all the systems we have discussed so far in the human body, the reproductive system is not necessary for the survival of the individual. This is true for both male and female. However, it is required for the survival of the species. Unlike any other system of the body, which are functional at the time of or shortly after birth, the reproductive system becomes functional much later at the onset of puberty. Anatomically and functionally, the female reproductive system can be divided into three main components: the ovaries, the reproductive tract, and the mammary glands. Generally, females have two ovaries, and they're the site of female gamete production, storage, and maturation. The ovaries are important endocrine organs that secrete estrogen and progesterone. The reproductive tract has three functionally distinct regions. The fallopian tubes, also known as the uterine tubes or the oviducts, are the main site of fertilization. They also serve as a passageway for transporting the zygote or the ovum to the uterus. The uterus is where the developing zygote will implant and where the fetus will develop. It is also critical for the delivery of the fetus. The vagina provides reception of male gametes and serve as birth canals during parturition. The breasts or the mammary glands provide nutrition for the newborn postpartum. The functions of different components of the reproductive system are integrated by the hypothalamus, pituitary, and ovarian hormones, in addition to a complex neurological pathways. With the exception of the breasts, which are associated with the anterior thoracic wall, the ovaries and the entire reproductive tract are located in the pelvis. The pelvis is a bony-shaped basin, and it can be located on yourself and your patient using the following surface landmarks. Bilaterally, the anterior superior iliac spine, ASIS, and the anterior portions of the iliac crest mark the anterior and superior aspect of the pelvis. At midline of the body, the pubic symphysis and the pubic tubercles can be palpated to mark the anterior and inferior surface of the pelvis. If you're sitting down at the moment, the bony area that is touching the seat is ischial tuberosity, and together they mark the inferior aspects of the pelvis. The great trochanter of the femur can be palpated on the sides of the legs. These surface landmarks give an approximation of where the femurs join the hip bones, which mark the lateral aspect of the pelvis. If you're standing up straight in the anatomical position, the ASIS and the pubic symphysis are in the same vertical plane. The pelvis is made up of two hip bones, the sacrum, and the coccyx of the lower spine. These bones are held together in the shape of a basin by ligaments and muscles. There's a bony ridge that runs along the sacral promontory, inferior to the iliac fossa, along the arcuate line on the ilium, and the superior pubic rami on both sides. This bony ridge indicated by the red line is known as the pelvic brim. The area the pelvic brim surrounds is known as the pelvic inlet. The area surrounded by the ischial spine, the coccyx, and the inferior edge of the pubic symphysis is known as the pelvic outlet. Anatomically, the pelvic brim divides the bony pelvis into the greater pelvis above and the lesser pelvis below. From this mid-sagittal view, the pelvic inlet can be marked by drawing a line from the superior edge of the pubic symphysis to the sacral promontory, and the pelvic outlet can be marked by drawing a line from the inferior aspect of the pubic symphysis to the coccyx. In anatomical position, the greater pelvis offers protection to the inferior abdominal viscera and bowels. The lesser pelvis provides the skeletal framework for the pelvic cavity and the perineum. The distal components of the urinary, reproductive, and digestive tracts occupy the lesser pelvis between the pelvic inlet and the outlet. The female reproductive system is an intricate arrangement of structures that can be separated into internal and external genitalia. The internal genitalia includes the structures within the lesser pelvis, such as the ovaries, fallopian tubes, uterus, cervix, and the vagina. Most of these structures are opening to the external environment, and it can change in size and volume significantly. They're being dynamically supported by ligaments and the pelvic floor muscles. The external genitalia comprises of structures outside the lesser pelvis and are suspended by the urogenital diaphragm, also known as the perineal membrane, which will be discussed in detail in a different podcast. The parietal peritoneum covering the lower anterior abdominal wall transitions into the visceral peritoneum as it reflects onto the superior surface of the bladder anteriorly, the female reproductive tract and the ovaries in the middle, and the anterior aspect of the rectum posteriorly. The coverage of the peritoneum helps support and anchors portions of the internal genitalia to the abdominal pelvic cavity and also accommodates for the changes that these organs might potentially occur. The ovaries play a fundamental role in the reproduction. They are the primary organs of the female reproductive system where female gametes are produced, stored, and matured. They're also responsible for the production of estrogen and progesterone. Embryonically, the ovaries descend from the mid-lumbar region of the posterior abdominal wall. Unlike their male counterparts, the testes, the ovaries do not exit the pelvis via the inguinal canals. The descent of the ovaries ends in the lower abdominal pelvic cavity near the uterus. The ovaries relocate into the ovarian fossa, located between the bifurcation of the external and the internal iliac vessels in the adults. Both the ovaries are suspended by its proximal end to the posterior lateral wall by the ovarian arteries and vein, as well as the nerve plexus and the lymphatic drainages of the ovaries. These structures are covered by parietal peritoneum. Collectively, they are known as the suspensory ligament of the ovary. The distal end of the ovaries are anchored to the superior aspect of the uterus on both sides via the ligament of the ovary. Female gametes, the oocytes, are stored and matured in the ovaries prior to being released into the peritoneal cavity during the process of ovulation. In this posterior view of the female reproductive system in the left pelvis, the ovaries are these oval-shaped organs on both sides of the reproductive tract. They're suspended by the suspensory ligament of the ovary and anchored to the uterus by the ligament of the ovary. The mesenteries of the ovary, created by the peritoneum associated with the ovary, also contribute to the support and the suspension. Average dimension of an ovary is 2 centimeters in width, 3.5 centimeters in length, and 1 centimeter in thickness. The volume of the ovary changes as females age. Around 70% of changes in ovarian volume may solely due to age. At 2, the volume of the ovary averages around 0.7 to 1 mil. At the peak of a reproductive age, in the early 20s, the volume can increase to as high as 7 to 8 mils. And after that, the volume will slowly decrease until menopause, where the average volume could be around 2 to 3 mils. After ovulation, the oocyte is released by the ovary into the peritoneal cavity to be picked up by the fallopian tubes, where fertilization and transportation to the uterus occur. The fallopian tubes are hollow muscular organs with a very complex mucosa. The fallopian tubes are 11 to 12 centimeters in length and have a lumen diameter around 1 millimeter. It comprises of 4 anatomically distinct regions. The ends that hug the ovary are also the most distal ends from the uterus. This funnel-shaped region, known as the infundibulum, ends at an opening in a peritoneal cavity. The fimbriae are these finger-like extensions of the distal infundibulum, and they're responsible for catching the oocytes released from the ovary after the ovulation. The ampulla region is medial to the infundibulum, and it is the most common site for fertilization. The isthmus is the region of the fallopian tube medial to the ampulla, where the lumen diameter decreases compared to the ampulla. Most medially, the intramural region includes a small opening into the uterus and a short segment nearest to the uterine horn. The uterus is a hollow, pear-shaped organ that is responsible for variety of functions such as menstruation, pregnancy, labor, and delivery. The uterus is a secondary sex organ that matures during puberty under the influence of ovarian hormones. The zygote is transported by the fallopian tubes and implanted to the inner linings of the uterus, where it receives nourishment from blood vessels developed specifically for this purpose. Anatomically, the uterus is located in the female pelvis immediately posterior to the bladder and anterior to the rectum. Depending on the condition of the bladder and the rectum, the position of the uterus in non-pregnant adult female can vary considerably. Majority of the adult uterus is usually anteverted or tipped forward and anti-flexed with a bent on itself. When the bladder is empty, the uterus typically lies in a nearly transverse plane on top of the bladder. And as the bladder fills, the uterus gradually becomes more and more vertical, until with a fully distended bladder, the top of the uterus may be directed back and towards the sacrum. The uterus may be rotated, especially during pregnancy, and other less common variation of uterine position exist that may or may not be associated with gynecological or obstetric issues. As many as 20% of the female may have a uterus in a retroverted or tipped backward position without any ill effects. The female uterus can be subdivided into 4 anatomical regions from the superior to the inferior. The fundus is the broad curved area in which the uterine tubes or the fallopian tubes connect to the uterus. The corpus or the body is the main part of an uterus. It starts directly below the level of the fallopian tubes and it tapers downwards and is flattened anterior-posteriorly. The isthmus is located in the lower neck region of the uterus, and the cervix extends downward from the isthmus and opens into the vagina. On a coronal cut section, the uterine cavity has a shape of an inverted triangle. The uterine cavity is lined by a layer of a mucosa known as the endometrium of the uterus. It makes up about 10% of the total uterine mass. The endometrium lining is critical for implantation of the zygote and the placental development that follows. The endometrium undergoes morphological and functional changes cyclically in response to the ovarian hormones in preparation for potential pregnancy. The outer muscular layer of the uterus is the myometrium. It makes up 90% of the total uterine mass. The myometrium is composed of circular, longitudinal, and oblique smooth muscle layers, which can generate force needed for delivery. And during menstruation, the uterus is enlarged and more vascular. The cervix is the cylindrical inferior one-third of the uterus. It is composed of 2 parts, a supravaginal part between the isthmus of the uterus and the vagina, and a vaginal part which protrudes into the vaginal vault and is known as the ectocervix. The cervical canal is continuous with the uterine cavity at a narrowing inside the isthmus of the uterus known as the internal os. The lower opening into the vagina is known as the external os and is circular in women. The shape of the external os are mostly dependent on whether a woman has given birth. During normal labor, the uterus contracts as the cervix dilates, and this results in the delivery of the infant. The uterus is approximately 7.5 centimeters long, 4.5 centimeters side to side, 3 centimeters thick, and weighing about 40 to 50 grams in a non-pregnant female. During a typical 40 weeks pregnancy, as the embryo grows and matures, the uterus expands and accommodates the developing fetus. And as a result, the abdominal contents are displaced. Other pelvic viscera are experiencing increased pressure and weight from the uterus. This can lead to indigestion and frequent urination. By the 8th month, the uterus typically reaches the epigastric region. The increase in size is partly due to the growth of pre-existing muscle and partly due to development of new fibers. After parturition, the uterus nearly regains its usual size, but its cavity is larger than its virgin state, and the vessels are more tortuous and its muscular layers are more defined. The vagina is a fibromuscular canal ranging from 6 to 8 centimeters in length that directs downwards and forwards. In 80% of women, the long axis of the uterus lies at a right angle to the long axis of the vagina. And because of this oblique nature of the vagina, the anterior wall is slightly shorter than the posterior wall. Usually, there is no space inside the vagina unless it is stretched open during examination, sexual intercourse, or childbirth. The vagina is located anterior to the rectum and posteriorly to the wall of the urinary bladder and the urethra. The lower third of the vagina is surrounded by elastic muscles that controls the diameter of its opening. The upper segment of the vagina surrounds the vaginal portion of the cervix. The narrow space between the cervix and the wall of the vagina is known as the fornix. The recess between the anterior lip of the cervix and the anterior wall of the vagina is the anterior fornix. The recess between the posterior lip of the cervix and the posterior wall of the vagina is the posterior fornix. The posterior fornix is the deepest and is a common site for ruptures, malignancies, and collections of foreign bodies. The vagina is lined with mucous membrane, kept moist by fluid produced by cells on the surface and the secretions from glands in the cervix. A small amount of these fluid may pass to the outside as clear or milky white vaginal discharge, which is normal. During a woman's reproductive years, the lining of the vagina has folds and wrinkles. Before puberty and after menopause, the lining is relatively smooth. The peritoneum drips over the pelvic organs like a sheet, and together with the space between the pelvic structures, it creates anatomical recesses or pouches in the pelvic cavity. The pouch created by the peritoneum covering the space between the bladder and the uterus is known as the vesico-uterine pouch. When we say vesicle, we're referring to the bladder. The pouch between the cervix, upper vagina, and the anterior rectum is known as the recto-uterine pouch of Douglas. When you're standing in the anatomical position, these pouches are some of the lowest points of the abdominal pelvic cavity and is ideal collection sites for pathological fluids and infection. To summarize, the female reproductive system produces female gametes and provides a site for fertilization, fetal development, and nutrients for the newborn. The pelvis is divided into the greater and lesser pelvis by the pelvic brim. Structures of the female internal genitalia are located in the lesser pelvis. The ovaries are suspended in ovarian fossa by the suspensory ligament of the ovary and anchored to the uterus by the ligament of the ovary. The distal end of the fallopian tubes surround the ovaries, and the proximal end joins the uterus at the region of the fundus. The uterus is located between the bladder and the rectum in an anteverted and anteflexed position. The inferior cervix of the uterus is surrounded by the vaginal wall. The vagina serves to receive the male gametes during sexual intercourse and as birth canal during delivery. The recto-uterine pouch of Douglas is the lowest point of the female abdominal pelvic cavity in the anatomical position.
Female reproductive system, the uterine and the ovarian cycles. At the end of this podcast, a competent student should be able to describe the 3 phases of the ovarian cycle, to describe the 3 phases of the uterine cycle, and to describe how the ovarian and the uterine cycles are integrated and modulated by the hypothalamus and the pituitary hormones. The ovarian cycle encompasses many complex events such as the formation and the growth of the ovarian follicles, the release of the secondary oocyte during ovulation, and the transition of follicular cells into temporary endocrine organ known as the corpus luteum. The ovarian cycle is a highly orchestrated process that relies on functional interactions among the oocytes, granulosa cells, theca cells, and surrounding stromal components, including the vascular and the immune systems. In the ovarian cortex, each follicle is a community of different cell types that works together and moves through the ovarian stroma and eventually either dies or ovulates and then delivers secondary oocytes for fertilization. The ovarian cycle starts with the follicular phase, in which a primary oocyte matures into becoming a secondary oocyte. At the end of each follicular phase, one oocyte is released during ovulation. Following ovulation, the ovarian cycle enters its luteal phase, in which the remainder of the ruptured follicle turns into the progesterone-producing endocrine organ known as the corpus luteum. Following puberty, gonadotrophin-releasing hormone secreted by the hypothalamus follows a cyclic rhythm. In the follicular phase, follicle-stimulating hormone causes growth of the ovarian follicles, and only one of which matures to become a graphene follicle. Follicular cells are the main producers of estrogen. The amount of estrogen secreted is a function of the size of the follicle. Many small follicles are required in the early stages of the ovarian cycle to secrete the required estrogen. As the follicle enlarges, one becomes dominant and it takes over estrogen secretion. Estrogen secreted by the developing follicles increases the sensitivity of the follicle to FSH, setting up a positive feedback loop promoting further estrogen secretion. The high concentration of estrogen produced in the follicular phase of the ovarian cycle serves as a positive feedback to promote a surge of luteinizing hormone release by the anterior pituitary. Luteinizing hormone initiates progesterone secretion by the developing follicle. Over a 24-hour period, this process causes the follicular cells to hypertrophy and proliferate. Luteinizing hormone induces the final maturation and the ovulation of the follicle. Luteinizing hormone also stimulates follicular granulosa cells to form a corpus luteum, which secretes progesterone and estrogen in the luteal phase of the ovarian cycle. Secretion of progesterone and estrogen by the corpus luteum decreases FSH and LH secretion by the anterior pituitary. In the absence of a fertilization and implantation, the corpus luteum degenerates and forms the corpus albicans 12 days after ovulation. The degeneration of the corpus luteum results in reduction of progesterone and estrogen secretion, which releases the feedback inhibition of FSH and LH, allowing the pituitary secretion of these hormones to resume for the next ovarian cycle. The uterine cycle is also known as the menstrual cycle. The uterine cycle is typically around 28 days and is composed of 3 phases. In the absence of pregnancy, the uterine cycle starts on day 0 when menses commence. During this phase, the functional layer of the endometrium is shed. This usually lasts about a week. The proliferative phase follows the destruction of the functional layer. Under the influence of estrogen secreted by the developing follicles, the functional layer of the endometrium is repaired. The progesterone secreted by the corpus luteum causes the endometrium to become secretory. and packed with blood supply in the secretory phase of the uterine cycle in preparation for implantation. The uterus is made up of an external smooth muscle layer known as the myometrium and an internal mucosal layer known as the endometrium. The endometrium has two layers, the striatum functionalis, or the functional layer, and the striatum basalis, or the basal layer. The functional layer is the superficial 2/3 of the endometrium that proliferates, secretes, and then sheds during the menstrual cycle in the absence of pregnancy. The basal layer is the deep 1/3 supporting layer of the endometrium that adheres to the myometrium. After the functional layer is shed during menstruation, the basal layer remains to regenerate the endometrium ready for the next cycle. In the proliferative phase, the endometrium thickens as the connective tissue is renewed. The proliferation of the functional layer of the endometrium is predominantly stimulated by estrogen, secreted by the developing ovarian follicles, and facilitated by the FSH. Simple tubular glands in the striatum functionalis open onto the surface. Estrogen causes the endometrial stroma to become deep and richly vascularized. The proliferative phase of the uterine cycle corresponds to the follicular phase of the ovarian cycle. In a secretory phase, facilitated by the luteinizing hormone, the endometrial glands in the functional layer of the endometrium becomes long and twisted like a corkscrew. The glandular secretion function to provide the initial nutrient support of the zygote and the fetus, and may have a role in maintaining adhesion. If the ovum is not fertilized, the degeneration of corpus luteum results in the loss of progesterone. Decreasing levels of luteinizing hormone and progesterone results in the shedding of the functional layer of the endometrium. During menses, the terminal arterioles in the functional layer contract, resulting in ischemia and the degeneration of the functionalis layer. The arteries rupture and the rapid blood flow dislodges the necrotic functional layer. The basal layer is unaffected. The uterine artery branches in the myometrium give rise to the arcuate arteries that circles around the body. Branching from the arcuate arteries, radial arteries takes the blood supply to the endometrial layer of the uterine wall. The radial artery further branches into the straight artery. The straight artery then turns into the spiral artery as it continues its course through the different layers of the endometrium. The basal layer of endometrium is supplied by the straight arteries and are unchanged throughout the cycle. The functional layer of the endometrium is supplied by the spiral arteries, and these arteries undergo dramatic changes under the influence of progesterone. If the ovum is not fertilized, the loss of progesterone and LH results in spastic contraction of the spiral arteries in the striatum functionalis and the shedding of the endometrial lining. Estrogen from the developing follicles stimulate the repair of the functional layer in the proliferative phase of the uterine cycle. The proliferative phase transitions into the secretory phase after ovulation triggered by the luteinizing hormone released from the anterior pituitary gland in response to the increasing level of estrogen. The progesterone and an estrogen from the corpus luteum causes the endometrium to become secretory and prepares it for implantation. The loss of progesterone and LH result from non-pregnancy will start the menstrual cycle again. The ovaries and the uterus work synchronously to prepare for pregnancy. Under the influence of hypothalamus and pituitary hormones, multiple primordial follicles enter development at the same time. But the ovaries only release one secondary oocyte every month after the onset of puberty. The developing follicles produce estrogen, which stimulates the repair of uterine lining after menses and triggers the release of LH. Luteinizing hormone triggers ovulation and the development of the corpus luteum, which secretes progesterone and estrogen. The corpus luteum hormones stimulate the functional layer of the endometrium to become secretive, which is critical in implantation and placental development. If the ovulated secondary oocyte is not fertilized, the corpus luteum transitions into corpus albicans and it decreases the release of progesterone. The withdrawal of progesterone and LH will initiate the menstrual phase of the uterine cycle. Female reproductive system, follicular development and ovulation. At the end of this podcast, a competent student should be able to describe the process of follicular development, to distinguish between primordial, primary, secondary, and mature follicles, and to locate the region of the ovary where follicular development occurs. The ovaries are almond-shaped female gonads in which the oocytes develop in the structure known as the ovarian follicles. There are also endocrine glands that produce reproductive hormones. In prepubertal females, the connective tissue capsule of the ovary is covered by a smooth layer of ovarian mesothelium, or surface germinal epithelium, which is a single layer of cuboidal cells that gives the ovarian surface a dull and grayish appearance when compared to the adjacent peritoneal mesovarium. After puberty, the ovarian surface epithelium becomes progressively scarred and distorted because of the repeated rupture of ovarian follicles during ovulation. This scarring is less in women who take contraceptives that inhibits ovulation. Deep to the capsule is a cortical layer in which ovarian follicles reside. A third layer beneath the cortex is known as the vascular medulla of the ovary. Primordial germ cells migrate into the developing gonad early in embryogenesis and differentiate into millions of oogonia. Between 3 and 8 months of gestation in a human embryo, some of these oogonia enlarges and develop into primary oocyte and enters the first meiotic division on the pathway to becoming gametes by meiosis. These primary oocytes become arrested in the prophase of the first meiotic division until the female becomes sexually mature. At sexual maturity, a small number of primary oocytes each month matures and completes the first meiotic division to become a secondary oocyte under the influence of follicular stimulating hormone produced by the pituitary gland. The maturation of oocyte occurs within the ovarian follicles located in the cortex of the ovary. An ovarian follicle contains the oocyte, a glycoprotein layer secreted by the oocyte, and the follicular cells surrounding the oocyte. Post-ovulation, the remainder of the follicle transitions into a temporary endocrine organ known as the corpus luteum that produces ovarian hormone necessary for uterine lining repair. Neonatal females possess approximately 1 million primordial follicles. More than 90% of these follicles degenerate by the time the individual reaches puberty. Typically, only one follicle achieves full maturity to release a viable ovum by ovulation. In primordial follicles, the oocyte is arrested in the latest stage of meiosis I. At this stage, the oocyte is surrounded by a single layer of flattened ovarian follicular epithelial cells. These cells continue to hypertrophy and proliferate to form many layers surrounding the oocyte. Eventually, these cells will become the granulosa cells, which is the major source of progesterone after ovulation. The primordial follicles are small and usually found close to the outer edge of the cortex. When primordial follicle is stimulated, the oocyte enlarges and the follicular cells divide. The oocytes synthesize a glycoprotein coat known as the zona pellucida. A primary follicle has 2 layers of follicular cells external to the zona pellucida. The layer closest to the oocyte are the granulosa cells developed from the follicular epithelial cells. The stromal cells of the ovary surrounding the follicle develops and forms a capsule-like theca cell layer external to the granulosa. Theca is a Greek word that means box. Theca cells and granulosa cells together produce and release estrogen into the systemic vasculature. A few primary follicles develop into secondary follicles. The transition occurs as the follicular wall thickens and follicular cells begin to secrete fluid. Only one secondary follicle is destined to further development. The amount of estrogen secreted is a function of the size of the follicle. So many of the small follicles are required in the early stage of the ovarian cycle to secrete enough estrogen that is required. As the follicle enlarges, one becomes dominant and it takes over the estrogen secretion. The secondary follicles look very similar to the primary follicles, except that they are larger, there are more follicular cells, and there are accumulation of follicular fluid in the intracellular space known as the antrum. The surrounding theca cell layer of the follicular cell now are differentiating into two layers. The theca interna is a layer that contains cells that secretes androgen and follicular fluid. The theca externa is more fibrous and composed of spindle-shaped cells. The fibrous theca externa merges with the surrounding stroma. The androgen are converted into estrogen by the granulosa cells. Estrogen enters the capillary bed within the theca and circulates throughout the body. Estrogen supports the growth of the endometrium after menstruation and maintains the function of reproductive organs and glands. The secondary follicle develops into a mature follicle, which is also known as a graphene follicle. The complex expands the cortex and stretches the ovarian wall. Oocytes now is projected into the antrum. The surrounding granulosa cells are now called the cumulus oophoris, which is a Greek term that means egg-bearing heap. These cells provide the oocytes with glucose metabolism and signaling. The first meiotic division is completed, and the oocyte now is a secondary oocyte. After the first meiotic division, most of the cytoplasm goes into the secondary oocyte. The other becomes the polar body, which is hard to see because of the lack of the cytoplasm. The oocyte, zona pellucida, and the follicular cells surrounding the oocyte are all expelled at ovulation and enter the fallopian tube. Once released, the oocyte begins its secondary meiotic division and goes only as far as metaphase 2. The meiosis 2 division only carries on and completes if the ovum is fertilized by the sperm. As the follicle matures and enlarges, it secretes increasing amount of estrogen. The high concentration of estrogen causes the anterior pituitary gland to secrete luteinizing hormone. Luteinizing hormone induces the cumulus oophoris to separate from the wall and stimulate the follicles to rupture. Oocytes release with its cumulus onto the surface of the ovary and into the peritoneal cavity. And now the cumulus are called corona radiata. Oocytes will be picked up by the infundibulum of the fallopian tube after it's being ovulated. Oocyte is transported down the fallopian tube by the ciliated epithelium and the contractions of the smooth muscle in the wall of the fallopian tube. Fertilization takes place in the ampulla of the fallopian tube, and the fertilized zygote travels down the fallopian tube to the uterus while commencing its development. The zygote will implant into the mucosa of the uterus. To summarize, ovarian follicular development occurs in the ovarian cortex, and multiple primordial follicles enter the development at the same time, but only one follicle reaches maturity and is ovulated. The remainder degenerates. Follicles are composite structures that include anocyte, xenopellucida, and follicular cells. Granulosa cells and theca cells are critical in the production of estrogen. The process of follicular development relies on the secretion of follicular stimulating hormone from the anterior pituitary and estrogen and progesterone secreted by the follicles themselves. Female reproductive system, blood supplies, and lymphatic drainage. A competent student at the end of this podcast should be able to identify the blood vessels associated with the structures of the female reproductive system above the pelvic floor, to identify the blood vessels associated with the structures located in the female perineum, to locate the anastomosis between the blood supplies to the ovaries and the reproductive tract, to describe the anatomical relationship between the uterine arteries and the ureter, to describe the 4 destinations of the branches of the internal iliac arteries will supply, and to describe the relationship between the terminal branches of the internal iliac vessels and uterosacral and the cardinal ligaments. The ovarian artery arises from the abdominal aorta between the renal artery and the inferior mesenteric artery. It is closer to the renal artery and is considerably superior to the inferior mesenteric artery. As it passes inferiorly, the ovarian artery adheres to the parietal peritoneum of the posterior abdominal wall and runs anterior to the ureter and usually giving branches to supplying it. As the ovarian artery enters the lesser pelvis, it crosses the bifurcation of the common iliac vessel into the external and the internal iliac vessels. The ovarian artery then runs medially, dividing into an ovarian branch and a tubal branch, which supply the ovary and the fallopian tube respectively. These branches anastomose with the corresponding branches of the uterine artery. The pelvis is richly supplied with arteries, among which multiple anastomoses occur, providing an extensive network of circulation. The internal iliac artery is the principal artery of the pelvis. Each internal iliac artery, approximately 4 centimeters long, begins as the common iliac artery. The bifurcation of the common iliac artery into the internal and the external vessels is at the level of intervertebral disc between L5 and S1 vertebra. The ureter crosses the common iliac artery at the bifurcation. Although the variations are common, the internal iliac artery usually ends at the superior edge of the greater sciatic foramen by dividing into an anterior and a posterior division. The posterior division is also known as the muscular branch, as it supplies the piriformis muscle, the gluteus medius and medius muscles posteriorly, and the musculoskeletal structures associated with ilium, sacrum, and the lower lumbar region. The anterior division of the internal iliac artery supplies most of the visceral and musculoskeletal components of the lesser pelvis, such as the bladder, rectum, and the reproductive organs. The anterior division branches also supply the medial compartment of the thigh, the perineum, and some gluteal region. The arrangement of the visceral branch is variable. In the lesser pelvis, the uterine artery is a direct branch of the internal iliac artery in females. It descends on the lateral wall of the pelvis, anterior to the internal iliac artery, and passes medially to reach the junction of the uterus and the vagina, where the ectocervix of the uterus protrudes into the superior vaginal canal. As it traverses medially, the uterine artery passes directly superior to the ureter on both sides of the uterus. The relationship between the ureter to the uterine artery is often remembered as by the phrase bridge over troubled water. On reaching the size of the cervix, the uterine artery divides into a smaller descending vaginal branch, which supplies the cervix and the upper vagina, and a larger ascending branch that runs along the lateral margin of the uterus and supplying it. The uterine artery traverses from lateral to medial at the base of the broad ligament and through the cardinal ligament. The ascending branch of the uterine artery bifurcates into the ovarian and the tubal branch, which continues to supply the medial end of the ovary and the fallopian tubes. The ovarian and tubal branches of the uterine artery anastomose with the corresponding branches of the ovarian artery. The vaginal artery is the homolog inferior vesical artery in the male. It often arises from the initial part of the uterine artery instead of arising directly from the anterior division of the internal iliac artery. The vaginal artery supplies numerous branches to the anterior and posterior surface of the middle portion of the vagina. The artery supplying the superior parts of the vagina derives from the uterine artery, and the artery supplying the inferior parts of the vagina derives from the internal pudental artery. Veins draining the ovaries from a vein-like pampiniform plexus in the broad ligament near the ovary and the uterine tube. The veins of the plexus usually merge to form a single ovarian vein, which leaves the lesser pelvis. The right ovarian vein ascends to enter the inferior vena cava. The left ovarian vein drains into the left renal vein. The vaginal veins form the vaginal venous plexus along the sides of the vagina and within the vaginal mucosa. These veins are continuous with the uterine venous plexus as the uterovaginal venous plexus, which drains into the internal iliac veins through the uterine vein. This plexus also communicates with the vesical and rectal venous plexus. The tubal veins drains into the ovarian veins and the uterine or the uterosacral venous plexus. The internal pudental artery, larger in males than in females, passes inferolaterally and anteriorly to the piriformis muscle and the sacral plexus. It leaves the pelvis between the piriformis and the coccygeus muscle by passing through the inferior part of the greater sciatic foramen. The internal pudental artery then passes around the posterior aspect of the ischial spine and enters the ischial-anal fossa of the perineum through the lesser sciatic foramen. As it passes anteriorly to reach the structures within the urogenital triangle of the perineum, the internal pudental artery, along with the internal pudental vein and the pudental nerve, pass through the pudental canal in the lateral wall of the ischial-anal fossa. As the internal pudental artery exits the pudental canal, medial to the ischial tuberosity, the internal pudental artery divides into its terminal branches in the deep pouch as the artery of the clitoris and the vestibular bulb, in a superficial pouch as the perineal arteries, and supplies the perineal and the posterior labial region and inferior rectal region of the perineum. The internal pudental artery supplies most of the skin, external genitalia, and the perineal muscles. Clitoral vein, vestibular bulb vein, and the labial vein in the urogenital triangle, and the inferior rectal vein in the anal triangle are tributaries of the internal pudental veins. Venous engorgement in the plexus of the vestibular bulb during the excitement phase of the sexual response causes an increase in the size and the consistency of the clitoris and the vestibular bulb of the vagina. Pelvic venous plexus are formed by interjoining veins surrounding the pelvic viscera. These intercommunicating networks of veins are clinically important. The rectal, uterine, vaginal, vesical or bladder plexus within the lesser pelvis, and the vestibular bulbar plexus in the perineum unite and are drained mainly by tributaries of the internal iliac veins. But some of them drains through the superior rectal vein into the inferior mesenteric vein of the hepatic portal system, or through the lateral sacral veins into the internal vertebral venous plexus. Tributaries of the internal iliac veins are more variable than the branches of the internal iliac artery with which they share names, but roughly accompanying them. draining the same territories that the artery supply. The internal iliac vein merges with the external iliac veins to form the common iliac veins, which unite at the level of vertebra L4 or L5 to form the inferior vena cava. Pelvic lymph nodes are closely clustered around the pelvic vessels, the lymphatic drainage often paralleling venous flow. The lymph nodes receiving lymphatic drainage from pelvic organs are variable in size, number, and location. They're mostly clustered in the following locations. All the structures of the female external genitalia, also known as the vulva, is drained by the inguinal lymph nodes. The labia majora and minora, the clitoris, vestibular bulbs, and the greater vestibular glands and vaginal opening are drained by the lymph nodes found below the inguinal ligaments and within the femoral sheath medial to the femoral vessels. The inguinal lymph nodes drain into the external iliac lymph nodes. External iliac lymph nodes lie above the pelvic rim along the external iliac vessels. They receive lymph nodes mainly from the inguinal lymph nodes. They also receive lymph from pelvic viscera, including the female internal genitalia, especially the superior parts of the middle to anterior pelvic organs. The external iliac lymph nodes drain into the common iliac nodes. Internal iliac lymph nodes cluster around the anterior and posterior divisions of the internal iliac artery and the origins of the gluteal arteries. They receive drainage from the inferior pelvic viscera, deep perineum, and the gluteal region. The internal iliac nodes drain into the common iliac nodes. Sacral lymph nodes lie in the concavity of the sacrum, adjacent to the medial sacral vessels. They receive lymph nodes from posterior inferior pelvic viscera and drain either to internal or common iliac nodes. Common iliac lymph nodes lie superior to the pelvic rim, along the common iliac blood vessels, and receive drainage from inguinal, sacral, external, and internal iliac nodes. These nodes are linked by a common route for drainage to the lumbar nodes. The neck of the bladder and inferior vagina are two of the pelvic organs with inconsistent but direct drainage to the common iliac nodes. Additional minor groups of nodes, such as the pararectal nodes, can be found in the connective tissue along the branches of the internal iliac vessel to the region. All groups of pelvic nodes are highly interconnected to build a redundancy in the lymphatic drainage of pelvic organs. The interconnection also allows cancer to spread in virtually any direction to any pelvic abdominal viscera. To summarize, the internal iliac vessels are the main vessels of the female lesser pelvis. The internal pudental vessels are the main vessels of the perineum. The ovarian and the tubal branches of the ovarian and the uterine vessels anastomose with each other. As the uterine artery goes from the lateral pelvic wall to the cervical region, it travels superior to the ureter on either sides of the uterus. The internal iliac artery supplies the medial compartment of the thigh, the gluteal region, the lesser pelvis, and the perineum. The uterosacral ligament is closely associated with the vaginal artery, and the cardinal ligaments contains the uterine artery. Female reproductive system innervation. A competent student at the end of this podcast should be able to identify the sympathetic innervation to the female reproductive system, to identify the parasympathetic innervation to the female reproductive system, to identify the somatic innervation to the female perineum, and to describe the level of the pelvic pain line. The female reproductive tract is embedded with a rich ground plexus of somatic and autonomic nerves that regulates vascular and non-vascular smooth muscle contractile activity, glandular secretions, immune cell interactions, and convey information to the central nervous system regarding the internal environment and potential noxious stimuli. Nerves of the female reproductive system enters the lesser pelvis via 3 different routes: the periarterial plexus, the hypogastric plexus, and the splanchnic nerves. The periarterial plexus are the postsynaptic sympathetic vasomotor fibers to the ovarian and the internal iliac arteries, and their derivative branches. These plexus can be located along the ovarian vessels within the suspensory ligament of the ovary and around the internal iliac artery branches. Similar to the blood supply, the nerve supply of the ovary derives mainly from the ovarian plexus descending with the ovarian vessels. The ovarian plexus contains sympathetic motor innervation from the lower thoracic T10 to 12 spinal segments via the lesser and the least splanchnic nerves. Sympathetic innervation appears to play an important role in the prepubertal development of the ovarian function. The parasympathetic innervation of the ovary stems from two sources. The main contribution is from the vagus nerve. The other contribution is from the pelvic splanchnic nerves via the inferior hypogastric plexus. Visceral afferent sensory fibers from the ovary follows the sympathetic fibers retrograde back to the central nervous system. The hypogastric plexus is the most important route by which postsynaptic sympathetic information and presynaptic parasympathetic fibers are conveyed to the pelvic viscera. Visceral afferent fibers transmitting sensory information back from the pelvic organ follows the sympathetic and parasympathetic motor fibers retrograde back to the central nervous system. These fibers are also part of hypogastric plexus. The hypogastric plexus is further subdivided into the superior and inferior hypogastric plexus. The superior hypogastric plexus is located centrally and anteriorly to the L5 vertebral body and the sacral promontory, whereas the inferior hypogastric plexus lies bilaterally within the presacral connective tissues on either side of the rectum at S2 to S4 vertebral levels. Although the sympathetic component largely produces vasomotion as elsewhere, here it stimulates contractions of the internal genitalia during an orgasm. The superior hypogastric plexus lies in the retroperitoneum bilaterally, extending from the lower third of the fifth lumbar vertebra to the upper third of the first sacral vertebra. It contains mostly of postsynaptic sympathetic fibers from T10 to L2 spinal levels. The visceral afferent fibers from the majority of the female reproductive system follows the sympathetic fiber retrograde to the superior hypogastric plexus back to the T10 and L2 level of the spinal cord. The main part of the superior hypogastric plexus is a prolongation of the nerve plexus, which lies anterior to the bifurcation of the aorta. The superior hypogastric plexus enters the pelvis and dividing into the right and the left hypogastric nerves. That descends lateral to the rectosigmoid junction to reach the two inferior hypogastric plexus. The superior plexus gives off branches to the uteric and ovarian plexus, the sigmoid colon plexus, and the plexus that surrounds the common and internal iliac arteries. Although commonly described as a plexiform structure, several morphological variations exist. Damage to the superior hypogastric plexus can occur during anterior and anterior lateral approaches to the lumbar sacral spine, leading to the dysfunction of abdominal pelvic viscera. The inferior hypogastric plexus is a flat retroperitoneal network of nerves lie on either side of the rectum, lower part of the bladder, and uterine cervix and the vaginal fornixes. In contrast to the superior hypogastric plexus, which is situated in a predominantly longitudinal plane, the configuration of the inferior hypogastric plexus is oriented more transversely, extending posterior inferiorly and parallel to the pelvic floor. It ranges from 3 to 5 centimeters long by 2 to 5 centimeters high, extending as far as 1.5 centimeters posterior to the dorsal edge of the rectum and 1 centimeter superior to the rectal uterine pouch. Because of its location and configuration, the inferior hypogastric plexus does not lend itself to surgical or chemical interference. The inferior hypogastric plexus is formed from the fusion of superior hypogastric plexus, pelvic splanchnic nerves, and visceral afferent fibers. Within the pelvic plexus, the sacral, and the pelvic splanchnic nerves are responsible for innervating the pelvic walls and vessels, as well as the pelvic organs that are present in that region. Pelvic splanchnic nerves arise in the pelvis from the anterior rami of S2 to S4 spinal nerves of the sacral plexus. They convey presynaptic parasympathetic fibers derived from the S2 to S4 spinal cord segment, which makes up the sacral outflow of the parasympathetic cranial sacral nervous system, and the visceral afferent fibers from cell bodies in the spinal ganglia of the corresponding spinal nerves. The parasympathetic fibers distributed within the pelvis stimulate the contractions of the rectum and the bladder for defecation and urination. Parasympathetic fibers penetrate the pelvic floor to reach the erectile bodies and the external genitalia to produce erection. The pelvic splanchnic nerves carries the parasympathetic fibers and provides innervation to the subperitoneal viscera, such as the cervix and upper vagina. Visceral afferent fibers from the inferior portion of the pelvic viscera follow the parasympathetic fibers retrograde through the inferior hypogastric plexus and the pelvic splanchnic nerves to reach the cell body in the spinal sensory ganglia of S2 to S4. The sacrosplanchnic nerves connects the inferior hypogastric plexus with the sacral portions of the sympathetic trunk. The sacrosplanchnic nerve provides both motor and sensory information to the muscles of the pelvis. The major branches of the sacrosplanchnic nerve is a component of the pudendal nerve to the perineum. The uterovaginal nerve plexus is one of the pelvic plexus that extends to the pelvic viscera from the inferior hypogastric plexus. Sympathetic innervation originates in the inferior thoracic spinal cord segments and passes through the lumbar splanchnic nerves and the hypogastric plexus. Parasympathetic innervation originates in the S2 to S4 spinal cord segment and passes through the pelvic splanchnic nerves to the inferior hypogastric uterovaginal plexus. The visceral afferent fibers to the uterus and the vagina is also a component of this plexus. The uterovaginal plexus travels with the uterine artery at the junction of the base of the broad ligament and the superior part of the cardinal ligament. All visceral sensory fibers conducting reflexive sensation travel with parasympathetic fibers. In the case of the pelvis, they travel through the inferior hypogastric plexus and the pelvic splanchnic nerves to the spinal sensory ganglia of the S2 to S4 spinal nerves. The path followed by the visceral afferent fibers conducting pain from the pelvic viscera differ than the general visceral sensation in terms of course and destination, depending on whether the structure from which the pain is emanating is located superior or inferior to the pelvic pain line. Except the rectum, the pelvic pain line corresponds to the inferior limit of the peritoneum. Intraperitoneal abdominal pelvic viscera, or aspects of the visceral structures that are in contact with the peritoneum, are superior to the pain line. Visceral sensory fibers conducting pain impulses from these viscera follow sympathetic fibers retrograde, ascending through hypogastric plexus, abdominal pelvic splanchnic nerves, lumbar sympathetic trunks, and wide rami communicants to reach the cell bodies in the inferior thoracic and upper lumbar spinal ganglia. The ovaries and uterine tubes are intraperitoneal and therefore are superior to pelvic pain line. Subperitoneal pelvic viscera are structures inferior to the pain line. Afferent fibers conducting pain impulses from these viscera follow the parasympathetic fibers retrograde through the inferior hypogastric plexus and pelvic splanchnic nerves to reach the cell body in the spinal sensory ganglia of S2 to S4. The two different routes followed by the visceral pain fiber is clinically significant in that it offers the mothers a variety of types of anesthetics for childbirth. The pudendal nerve is the main nerve of the perineum and the chief sensory nerve of the external genitalia. The pudendal nerve stems from the sacral plexus, which is located on the posterior lateral wall of the lesser pelvis. Most branches of the sacral plexus leave the pelvis through the greater sciatic foramen, There are two main nerves arising from the sacral plexus, the pudendal nerve and the sciatic nerve, which supplies the posterior aspect of the thigh and the entire leg and foot. Accompanied by the internal pudendal artery, the pudendal nerve leaves the pelvis through the greater sciatic foramen between the piriformis and the coccygeus muscle. It then hooks around the ischial spine and the sacrospinous ligament and enters the perineum through the lesser sciatic foramen. Only the inferior 1/5 of the vagina has somatic innervation, which is from the deep perineal nerve, a branch of the pudendal nerve, which conveys the sympathetic and visceral afferent fibers to the perineum and external genitalia. Only this somatically innervated part is sensitive to touch and temperature, even though the somatic and visceral afferent fibers have their cell bodies in the same S2 to S4 sensory spinal ganglia. Most of the vagina, superior 3/4 to the 4/5, is visceral in terms of its innervation. To summarize, the sympathetic innervation to the female reproductive system stems from T10 to L2 spinal levels. The nerve fibers descend into the lesser pelvis and reach the target organs via the hypogastric plexus. The parasympathetic innervation to the female reproductive system stem from S2 to S4 spinal levels. The nerve fibers reach the target organ via pelvic splanchnic nerve and the hypogastric plexus. The somatic innervation to the female perineum stems from S2 to S4 spinal levels. The pelvic pain line corresponds to the inferior limit of the peritoneum. Visceral pain fibers from intraperitoneal pelvic viscera follow sympathetic fibers retrograde to T10 to L2 level. Visceral pain fibers from subperitoneal pelvic viscera follow parasympathetic fibers retrograde back to S2 to S4 levels.